the larynx. The lungs, you can do with MLC. What about the larynx? Can you do the larynx shield with MLC?
One field. It seems like if you were doing two side by side, you can maybe.
What do you mean two side by side?
If you're treating one side, use the MLCs just to block it on this side, and then if you're treating on the opposite side, use the MLCs to block on that.
You're doing the whole chest.
So one whole
Yeah.
field, then I would say just to design custom block.
Okay. How would you do that? How would you design a custom block?
Sarah, are you talking about pouring it, like the actual steps?
You haven't done that yet, have you?
We've done one. It's really cool looking.
With electrons?
Very heavy.
Well, very heavy. So what was it? What was the blocks for?
Electrons.
Well, no, then you're not doing it. Then this would be photons, right?
Yeah.
How thick are the electron shields that you've used? Electron.
What did we use?
It was an electron.
It was thick. It was like
Yeah,
2 cm.
Yeah.
Maybe?
that's not thick. Remember,
That's not what you would use for the larynx. Yep.
This is your thickness.
No, we didn't. We made a small one, then a little baby one.
So basically you would do something like this, only it would be a very thin, about yay deep, and about a centimetre wide, about this size. About this by about this.
That's
And then you-
that big. didn't
You
it?
can either
It wasn't that
place
big, but it was
on
electron.
a tray, or more likely, you would place it on, just a tray, not with a block on it. You put the tray in, and then you would hand place it on the tray to cover the larynx. How do you figure out where the larynx sits? It's easy on a guy. Why? How is that? So what do you do for the girls? What do you do for your female patients? How do you find out where the larynx is for your female patients?
Have them swallow. Can you feel it move with the swallow?
Yeah, you have to have your finger over it, usually one finger. And you put it where you think it might be, and have your patients lying flat like that, with their head up. And you ask them to swallow. And then you find out where they are, you put your finger there, and then somebody else puts the block right over your finger. Remember, it throws a shadow, right? So you have to cover where your finger is, and that is your larynx. The lung, you do MLC.
I need to go get a sandwich. I didn't
So,
like anyone.
Patient positioning, supine, arms akimbo or above the head. Everybody knows what I mean by arms akimbo.
Above the head. Above the head.
Can go with like this.
Yeah, it's actually like that.
Never mind.
You can actually use that, that's actually a reasonable technique. However,
I can't.
we'll get there eventually. Chin extended, and then an alpha cradle or backward. However, you have to decide, or the doctor has to decide, whether you're doing a mantle and also an inverted Y. So is he going to be, at one point or another, treating the mantle or the upper and then the lower? there's usually a break between them. 3 weeks to a month between doing the upper and the lower. So what are the problems with doing that? Do you plan them separately? Yeah, you have to. However, the patient should be in the same position, upper and lower. So normally if you're going to do both at one point or another, it's easier if you use a full body backlog. And I know that I believe that Shan's Gainesville has full bodies. So does the Proton Center. Anybody else seen full body backlogs? Okay. In that case, it would be, the patient would be treated with 2 backlogs, one above, one below. One for the shoulders, one for the hips. Chin extended. How do you get your patient to keep still with their chin extended?
Tape their head.
Tape their head, okay? The taping their head going to keep their chin still?
Sometimes they put on both chin and forehead.
Well, taping the chin is actually better than just taping the head. When you're CTing these patients, you should take a chin to SSN distance. Which means if you're CTing and you have the chin taped, you want to take a measurement from the chin here to the SSN. Should around 11 centimeters.
Thank
So
you.
that makes sure that you know where the chin has to be. Give me some other way to keep the chin up. A mask. Some patients will have a mask. You have to keep the chin up. You can cut the eyes and the nose and mouth out just to keep the chin up. And that would solve the problem of it. You still need the chin to the SSN distance, just to make sure. So when you're CTing these people, what about tattoos? Where do you put the tattoos? Same as usual. Where do you normally put your marks?
Laterals and you have 2 sets if you're doing the mantle and the inverted Y.
Well, you're not going to CT them both together.
They just have to have them separate sets of tattoos for each, though. They have upper and
Yes.
lower.
Yes, but let's forget that just for a minute. So you have a tattoo for the center and 2 tattoos here, right? So the hands are up, you have a tattoo here and 2 tattoos here. Or a tattoo on each side.
Good.
The other thing is, the other tattoo that you need, and this has to be a tattoo, even if you don't use tattoos normally. You should have a tattoo on the midline at the lower border of your field. Why?
You don't accidentally overlap.
So when you're doing the lower inverted Y, you should make sure that you're not going to overlap. So even if you're just using marks on the rest, please do a tattoo in the center of the lower border, or the inferior border, because that is critical, because you don't want to overlap. So 4 to 6 MB, usually it's 6 MB these days. Off-axis points. If you're doing things like, let me show you what matching looks like. There's your lower border. Your neck is coming in here. You have shielding here and shielding here. So what would this be? Humeral heads, yeah. You may or may not do those, depending on the physician. So you have humeral heads and you have the lung blocks. That's really all you have. And you have this teeny tiny little, that's the larynx shield. Anybody care to guess about a dose? Welcome back to that.
Let's take a look it up.
And then of course you do APPA. You need to do a larynx shield on PA.
Seems like you would. It still goes through the body, you still have exit dose, so if you're treating from one side.
Is the exit dose enough to cause problems with the larynx? Probably not. Or Laura? No. Because some physicians like to do a cervical shield, the cervical spine. And that also includes the larynx covered line. But you don't really need to do a spinal shield because most of the treatment is about 3,500 centigrade. So it doesn't reach the amount of dose you'd start getting worried about the spine. Okay, morbidity. Occipital epilation. Why?
Your head is tilted back, then that area is now
Mm-hmm.
in the treatment.
So you're treating from here over and from the occiput down, you lose the hair.
I imagine, do you get folds in the back of your neck back there? Does it get pretty raw?
No, it actually doesn't. It doesn't actually. So dysphagia and sore throat, because remember, you're only shielding this little larynx part. The rest of your throat, you have to treat because there's nodes running along. So you have to treat them. And nausea, because you're going fairly low. And xerostomia. Which is what? Gives you a clue there. Their salivary glands are included.
Dry mouth.
Hmm?
Dry mouth.
Dry mouth. And you can also get a sore mouth as well because you may be getting a little bit of the floor mouth into the tree. Bless you. Okay. So let's leave that. We'll come back to that in a minute. Soft tissue sarcomas. So Ewing's and osteosarcoma. And metastasis. So has anybody seen an extremity treated yet? Which one?
It was a
Leg?
lower leg. Yeah.
Lower leg? Lower leg? Anybody seen an arm or a shoulder treated yet? Okay. Brachial plexus. So that was included in the arm? Okay. How difficult was it to make the arm or reproducibility?
It depends on who you ask because he just laid down for Molly every single day. But when we switched, I had to, I spent like 20 minutes manipulating his arm. So I don't know.
So assertive with your language.
It is, who else has done an arm? Was it difficult to reproduce?
No, but it wasn't positioned right. So,
Okay.
no, yeah.
Okay. Which part of the arm? The forearm or the shoulder?
Oh, yeah.
What was yours?
Weren't you going to comment? Did you do it?
Yep.
Like four.
I'm gonna tell her. I'm just gonna ask me questions.
So-
I'm not gonna know the answers.
Lower
Do it. Tell her about it.
That one was hard, that one was.
Yeah.
You
So
did a what?
Basically the whole arm?
Mm-hmm.
Oh, hold on.
We had him in a full mold, so he was out like this.
Yeah.
And he laid both, so all we had to do was move the parameters and kind of stuff.
Yeah.
He stood up pretty well, but he was,
Tall dude. So did it rotate, did the machine rotate around him quite?
we did half arcs treatment.
Oh, I did a whole leg. I
half
forgot.
arcs? What?
Gainesville. I said I did a whole leg in Gainesville. I forgot.
Yeah. So the majority of the time, if you ask the therapist, what would be the most difficult treatment to treat, apart from treating kids and the whole body or the whole CNS, what would be the most difficult to treat? 99 times out of 100, somebody would say the arm. Because you can treat it this way, 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 you know. And it's really very difficult to immobilize it so that everything works beautifully. What about metastasis? Say spine. How do you position your spine, a patient with a spinal tumor?
We had one that was just on the pad on the table.
Prone or supine? Supine, okay. Supine? Anybody treat one prone yet?
No.
What would be what would make it easier to treat a patient prone? Why might we want to treat a patient prone for a spinal tumor if the patient was able to do that? Why might we want to treat a patient prone? Yeah, but that's not really the reason. It helps if you're lucky enough to have a patient who says, oh yeah, I can lie on my belly. You get them on their belly. you CT them that way. Then they go to treatment, patient lies down, and the doctor wants the treatment field centered on spine. If you're lying prone, if the patient is lying prone, you can actually feel the spine, right? So it's much easier to center on spine. And it's much more stable. Whereas if you treat them supine, you're centering on the marks, and then you swing around, and the only way that you know that it's centered is if you do a film or an image. Then you see it's centered on spine or not. Unfortunately, there's a lot of patients can't lie prone. But ideally, prone is much better. So, if you're simulating extremities, reliable immobilization. Make sure you can actually immobilize your patient. And make sure that you can immobilize them in such a way that it is reproducible for the patients or the therapist on the machine to treat. Wire. Why would we need wire? Why would we use wire? If you want to see where the scar is on the film, if we had surgery, you want to see where the scar is on the film, put a piece of wire across it. Or if there's a lump there, you can wire the lump. So you can do any of these if you want to. You can do them with 3D, non-IMRT, or you could treat them with IMRT. We'll get into that a little bit. Okay, TBI. Low dose chronic lymphocytic leukemia. High dose, which is what we normally use for stem cell transplant or bone marrow transplant. Patient can lie supine, prone, on their side, sitting up, fetal position, you name it, it's been done. 120, usually I wouldn't go as far as 200. 120 BID for a total of about 1,200.
I have a question. So say somebody, this is like, say I got cancer, right? And I already have low blood platelets, but treatment causes low blood platelets. I also can't get transfusions.
Okay.
I get infusions of like Rituxan
Yeah.
and stuff like that, but I don't know why I can't get infusions. I don't know the
So they
reason.
don't give you platelets every so often?
I don't know why I can't get transfusions, something with my blood.
Okay.
It's because they said it'd be pointless for me to get transfusions because my body's attacking them. It's not that I don't make enough.
Okay.
So if I were to get out of body platelets,
Right.
it would just do the same thing, but my body would freak out more and
Okay.
attack harder. And then if I'm not getting transfusions,
So it's
like,
an immunity system.
Yeah.
Immunity problem.
yeah, my body just
Yeah.
attacks itself
Right.
constantly. But
Mhm.
if I got this, obviously lowers your platelets, like chemo
Oh, yeah.
and stuff. How would they combat that?
They probably
You
wouldn't.
probably
they
wouldn't,
probably
yeah.
wouldn't do it.
I would just have. Oh, I was about to say I would just have
If you're
zero
gonna
platelets. I just start internally bleeding.
If the idea is that you would be doing a TBI,
Mm-hmm.
TBI drops the platelets. There's no way getting around that, because basically you're treating all of the bone marrow, which of course produces the platelets, right? So you probably would not be given a TBI.
Oh, okay.
That's a short answer.
Yeah.
Because there's no way we could give you platelets to counteract that.
Yeah. Interesting. You just die. That's cool.
Okay, so as I said, extended FSD, the field size, 40/40, extended SSD, and the patient would be sitting, reclining, supine, prone, fetal position, whatever you're doing. Let me get to another one that's a little more.
I need to go get a sandwich.
Go get one. I want another cupcake. No, don't do it. Don't do it.
Okay, so curative external beam may be considered with early stage disease, so 1A or 2A. Immobilization backlog, full body, hands at sides, as I say, a pimple or above the head. Upper and lower areas are to be treated. Patient must be in the same position. Must be in the same position for both. So, doses range depending on the age of the child or the adult from 20 gray to 36 gray. Fractionation 1.8 to 2, and the consideration given to a boost if necessary to a particular site. Involved site radiation therapy alone is 30 to 36. Pediatric patients will only give 21 to 24 gray. Because the majority of these kids have chemo as well as radiation. Mycosis fungoides. How do we treat that? How do we treat mycosis fungoides? With
Rotisserie.
electrons. Pardon?
Rotisserie.
What?
With electrons.
You're a
That-
rotisserie.
Thanks.
This is so
You go in a big
fresh
box
before it's gone.
and
Block is always a hit at parties.
So if you have a patient who has a small area of mycosis fungoides. Oh, I didn't bring any more.
there's crackers.
There's crackers.
Not that interesting. Okay.
They're Filipino crackers.
Oh, they're Filipino crackers, aren't they?
Yeah. There's a ton of cheese.
Chinese crackers.
No, they're
Packaged
Filipino.
in Philippines.
He's
Um,
tripping.
So, to get back to my
They're
subject, guys. If
is
you
the
have a small area
That's the most important subject.
of mycosis fungoides, you treat it with electrons, right? How do you position it? En face. En face, and what does that mean?
Parallel to the lesion that you're treating.
So the treatment applicator should be parallel to the treatment volume. Okay? however, you have an advanced disease, if you have an advanced disease, you treat whole body electrons. Anybody seen that yet? I know they do it at Shan's.
Total skin.
Oh.
The total skin.
Full skin.
Yeah.
Yeah.
That's what I've been talking about.
You
I'll
treated
listen.
that?
Yeah.
What position are the patients in?
That was
Standing.
the rotisserie, wasn't it?
Yeah.
What?
The rotisserie. He goes in this
Big
up on
box.
like a platform that rotates, and he holds onto these bars,
Mm-hmm.
and they rotisserie. I think it's literally in the chart as rotisserie.
Yeah.
That's what they call it.
So for those of us who have never seen it, do we have a cone, an electron cone on the
Yeah.
neck? What
Yeah.
size?
I don't know. 10 by 10. No, 20. Is it the bigger one?
Biggest
I
one?
don't, probably. Yeah, that would make the most sense.
So what's the biggest one?
20.
Pardon?
Is it 20?
You think I don't think-
25?
I think it's 25, but I don't know if they have 25.
I haven't seen it.
I don't think they have one.
There's
I think they have a 20.
20.
But
Yeah.
really, I can't
If
be
you
so
have a
sure. Steven, do you know
25
more?
If you have a 25, you should do
Steven's not
25.
even paying attention. Steven, do you know more? Okay.
Okay. So. So beam energies. What energy did you use for the TBI, or the TBE, I should say?
I just watched hers. Do you remember what the energy was? I didn't set it up, I just observed.
I don't. It's been too long.
Depending on the FSD or the SSD, patient was presumably fairly far away from the machine.
Yeah.
6 or a 12, 6 to a 12, so 6, 9 or 12. That's what you usually do, depending on how thick the lesions are. Because sometimes the lesions can be really thick. And if you use a 6 MV, it wouldn't go deep enough. So if you're using just, if you're treating small areas, then you'd use en face with electron cutouts. So classic total skin electrons, it says here, is delivered over 9 weeks, depending on what you're doing. 1 gray per day, 4 days a week, with a 1 week break after week 4. A boost treatment to bulky or symptomatic areas can be used.
Yeah.
If you're not using, as you quaintly put it, a rotisserie, and you're doing sort of one set, and then moving the patient, other set, moving the patient, other set. These are the 6 positions that the patient would have to be in to get most of the body covered. What part of the body would not be covered?
Feet.
Feet.
Bottom of the feet. I just knew you were gonna ask that, so I was ready. The bottom of the feet.
The bottom of the feet, the soles of the feet, yeah. Okay, let me go back to this other one, because I'm sure we missed one. Kaposi sarcoma and mycosis fungoides. Has anybody seen a Kaposi's?
Is that the one that's associated with HIV?
Some types. There are two types of Kaposi's. It's a classical and an age-related. You would treat it both with electrons.
What would happen if mycosis fungoides was just not treated? Would it eventually go internal?
If it was not treated, your skin would basically fall off. It would erode the skin.
So the patients that have to come back for retreat and retreat and retreat, they tend to do that for the rest of their life?
Uh-huh.
Until they just can't physically do it anymore?
Or unless they get it under control.
So there is a stopping point, or there can be a stopping point?
The stopping point would if they've reached the dose that they can give no more. Because remember, this type of one, you're doing whole body. There is a certain dose that most physicians wouldn't cross, yeah.
Yeah, just put me out. I'm
I'm just
good.
thinking of that, what's his name?
I know.
Can't remember his name.
Mucin. Oh,
Mucin,
I
yes.
It would be different if you were just. It usually comes in little bundles.
That sounds good.
Has anybody seen our Kaposi's? It's a sort of bluish,
You're naughty.
like a skin. You
No,
know
I'm
when
trying to
you-
swallow
you
my food.
bump your
You
arm and you get a bruise, a blue bruise.
I wasn't thinking about that
That's
shit.
what Kaposi's looks like. When we're done here, I've got some photographs that will show you. So morbidity from total electron. So you have erythema, surprisingly enough. Hyperpigmentation. What does that mean? Hyperpigmentation. Oh, yeah. Dry desquamation, conjunctivitis, extremity edema, decreased lacrimation, epilation of the eyebrows, eyelashes, and scalp, which makes sense. So, internal eye shields. Has anybody seen one yet?
Yes.
Yes. Yes.
It was horrible. Horrible looking.
Yeah, I'll be okay if I never have to apply them, but I will stand there and watch forever. But I
It's
don't.
not that bad to put in, actually.
I'm good.
So, small, medium, large. We usually use the medium one. And the majority of them are actually gold. They're covered in gold. And there's also, you see the little hole there?
Ours were white. It's for a string.
We usually put a string on so that we can keep an eye on them and make sure that they don't go anywhere.
And then you tape it to their face.
Keep an eye on the iPads.
So how do we put them in? Nothing, eye drops?
Uh-huh.
Not really, we do a local anesthetic to the eye, local anesthetic eye drops.
Mm-hmm.
So,
Arrow.
mind you, I had one physician who did it without local anesthetic and he refused to help them, so.
Oh, patients let him do that?
Disgusting.
Because the doctor said it was necessary, so
How the fuck?
we let him, we refused to help him. Anyway, The idea is that you numb up their eye. How do you know if the eyes are numb?
They can feel it.
Pardon?
So they can feel it, and it takes like they usually wait 1 or 2 minutes.
How do you know though that the eyes are numb? There's a test. You get a tissue, Kleenex tissue, and you open their eye, put the tissue against the eyeball, and if they flinch, it's not ready yet.
We didn't
They
do
just
that.
say, "Are you ready?"
Yeah, we didn't do that. We didn't do that.
Yeah. So anyway,
No, we didn't do that. We just waited a minute and a half.
Then-
Like,
you would put the eye shield, take the eye shield, you put it, you'd open this eye, ask them to look up, you put the eye shield underneath the lower lid, and then pull the upper lid up and ask them to look down, and then the eye shield will just slip underneath the upper lid. And taking it out, you do it backwards. You take it out of the upper lid first and then the lower lid. It's really easy once you get used to it. As I said, once you get used to it.
I don't want to. I don't want to get used to it.
I was so delayed.
Don't worry, well, why would we need to do that? Especially an internal eye shield. I mean, you can put external eye shields on, which are basically just curved pieces of lead with something over the top of them. If we're treating the cheek, for example, with electrons, they'll probably put an external eye shield over the top.
Well, because you might want to get the eyelids if you do an internal, and then
If you're treating the eyelid or the outer or inner canthus, sometimes the basal cell carcinomas come in the inner canthus and the outer canthus. So if you're treating either one of those, then you'd have to put an internal eye shield in. Because there's no way that you can treat properly if you have an external eye shield on. Because it would cover part of the treatment only. Okay. Metastatic disease. So we're going pain relief, which is most common. Improved breathing, which is the second most common. Or hemorrhaging. Pain relief, spine, hip, leg, arm, whatever. Anything that hurts, you treat. So if a patient says, comes in with, there's known metastasis in the hip, the femur, the T-spine, the L-spine, the humerus, you don't treat them all at once. You ask the patient which is the most painful. What part of the area is annoying you most? And they'll say, okay, whatever. Spine. My back's awful sore. That's the most painful part. You treat the spine.
we treated a femur and ribs at the same time.
So 2 areas.
Mm.
We
We did his femur, and then we get him down and change everything, and then put him back up and treat his ribs.
It's good if you don't have to do that.
Yeah, he was in a lot of pain.
Yeah.
That's probably why.
So that's probably why they did 2 areas. If you say had a problem with the hip, you may be able to do the spine and the hip following each other. So you do the spine and then you move the patient around and not moving them much to treat the hip. But if you have to get them up and turned around or whatever, it can be really difficult for your patient to do that. So improved breathing, lung. So it could be an obstruction of the spirea vena cava. It could be an obstruction in the thyroid, which is stopping you from breathing or stopping them from breathing well. Those are the 2 usual ones. Mediastinal obstruction, perhaps, as well. And then cessation of hemorrhage. And I'm not talking breathing, I'm talking hemorrhage, there's a difference. You have a patient who is bleeding from her vagina, or you have a patient who is bleeding from the bladder. That is urgent. I wouldn't say it's an emergency, but it's urgent. Yeah. What? Bladder? Or cervix? Cervix. Yeah. Yeah. So sometimes they can take them into, if they go into the ER, they can do something to stop the bleeding, but yeah. So that's basically. And then of course we have brain meds. 2001, 3002, or 801. 2001 week, 2002 weeks, or 800 is a single fraction. You'll never see that in the US, a single fraction. SVC obstruction, 400 times 3, then replan for palliation, or as per MD prescription. And that's the type that you get called in on the weekends to treat. And the spinal cord compression. Medicine epidural space. So if you're in UK or Europe, you would treat 2005. In the US, it's usually 3010. Or a single field of 800, a single treatment of 800. And any spinal cord or brain met, you have to use dexamethasone or Decadron, the other name for it is Decadron. And the depth of the spinal cord is 3 to 6 centimeters, depending on which part of the spinal cord you're in. And I'll send you all these. Okay, so let's take a break. 22, we'll come back.
I don't know about it.
And breathing therapy.
Couldn't tell you.
Internal radiation therapy.
I couldn't tell you. I just heard this.
Okay. Can you be a little more specific?
It does not come from the WINAC.
A little more specific. What does it use?
Mm-hmm.
Internal radiation.
What type of internal radiation?
Isotope.
Isotopes? Okay, what
Radioactive.
type of isotopes?
Radioactive.
What type of radioactive isotopes? Sealed, thank you. So there are sealed
Dang, I
and
thought about
there
saying
are
that.
unsealed. Can you give me an example of an unsealed source?
Cool. 60.
No,
Quartz.
No, that's, I remember that happened.
what do you use for thyroid? Iodine. Iodine what?
31.
131. Iodine 131, when it's used for treatment of the thyroid, is an unsealed source. You get it in a drink, or it's injected. Those are unsealed sources.
What's the amount of radiation typically given with that?
It's not, it's a matter of number of curies rather than a dose. And to be honest, I don't know the exact number these days, so I'll look it up. So brachytherapy comes from the Greek, brachy meaning near. So it is the treatment which is given internally, and the sources are actually put either close to or into the tumor site. So, the sources, the isotopes used in brachytherapy can be embedded into surface applicators which are placed directly onto the tumor. They can be inserted into a specifically designed apparatus that is placed into a body cavity, which surprisingly enough is called intercavitary, and into various tubular organs, which is intraluminal. So, or directly through the tumor, which is interstitial. So give me an example of each one of those. So, a surface applicator. So what type of area might we use a surface applicator on?
We use the surface applicator on someone's nose.
Yeah.
Face ones before
Yeah.
pictures on the face.
Yeah, basically, if you had something on the cheek, you could use a surface applicator, or on the back of the hand, or here, yeah, on the nose, or in the back of the hand. That would also be a surface applicator. What about intracavitary? Most common.
Isn't that the sabi that you're talking about?
No.
How is that different?
Well, let's go through them and I'll tell you. It's placed into a body cavity. What's the most common?
Your cylinder, your dosimetry.
So either vagina or cervix. The reason why I said no to the SAVI for intracavitary is it's not a body cavity. It's actually made by the surgeons.
Oh, okay.
That would probably, if you're gonna call it anything, it'd be an interstitial because it's going into the area.
So intracavitary would be inserting into a pre-existing.
Yeah, so cervix or the vagina or something like that. Into tubular organs, intraluminal. What's a tubular organ?
Like
Anybody?
a colon?
Yeah, you could do that, yeah. Try the other end.
Rectum?
No, the other end.
Oh, because I was gonna say, wouldn't that be intracavitary?
Esophagus.
Esophagus, esophagus, or
Any kind of vessels.
brachytherapy, or bronchus. That's the tubular organ. Interstitial. It's one that's done very, very commonly. Prostate, because it's going into the tumor.
That one just looks so bad.
Evil. There's another one which is called intravascular, where they actually have found that sealed sources can stop regrowth of the build-up plaque. You know, when you get plaque in the vein or the artery, and they put a stent in to open it up. Well, the stent only works for so long, and the plaque can come back. They found that if they're doing, they put in sealed sources, it actually stops it coming back. So it's called intravascular. Okay. So sealed sources. Radioactive material is sealed in a shell that prevents the escape of the radioactivity. Brachytherapy can be delivered in a short time as in HDR or LDR. So HDR is minutes, LDR is hours. Has everybody seen HDR done? Has anybody seen HDR done?
But wait, we can't.
Same.
HDR gynae. Okay. The LDR would be the permanent seeds for prostate. HDR would be temporary prostate seeds. So they would come in every so often and do that. And radioactive isotopes produce different types of radiation. So we have gamma, we have beta. Do we have alpha? Alpha particles are not effective for radiation therapy because they lack penetrating power. So no alpha. What stops alpha rays or
Sheet of
alpha
paper.
particles? Pardon?
Sheet of paper.
Sheet of paper. So that really would be no good, right? Beta particles are somewhat more penetrating. Their range is usually a few millimeters. These may be useful for very superficial lesions, especially in the eye. Beta isotopes are really good for eye plaques, treating the eye. And then gammas have more penetrating power and are commonly used in the treatment of larger tumors. So the shielding. Platinum or iridium, often built into the walls. So you have this radioactive source within a tube that's covered in either platinum or platinum and iridium to stop, twofold, to stop the soft radiation getting out and to shield the hard radiation until it's needed. Size and the shape of a radioactive source depends on how it is to be used. It can be the shape of a needle, seed, tube, or plaque. It may be also in solution. Unfortunately, most of the work was done on using radium, but we now don't use radium anymore. Why not?
bad ones,
Like what?
like deformed children.
No.
Was it the one with the people, the ladies that used the paintbrush to paint watches and
Yep.
stuff, and they had the
Mhm.
lesions on their mouth?
But I'm talking about using radium in treatment.
Well, that's
So-
their face.
Yeah. So why, apart from the radium girls is what they were called, radium watch girls, why did they stop using it?
You're going back like 3 semesters now.
Well, unfortunately, with the registry, you have to think back. One thing was that it was extremely expensive. What's the half-life of radium? Half-life of radium is what?
I was just reading about it in a review book, but I can't remember.
Approximately 1,600 years. Depending on what book you read, it says 1,600 or 1,620. But 20 years as opposed to 1,600 is, So you have 1,600 year half-life, which means it only gets to half its energy after 1,600 years. You really don't want to keep that stuff around for any length of time, because it would be X number of generations before they could send it away somewhere. And the other thing was that we never bought, radium was never bought, it was rented. So when you were finished with it, they got it back to the manufacturer. Also, what's the daughter product of radium? Radon? Mm-hmm. So what's the problem with radon?
Naturally occurring.
Yeah, so is radium.
Toxic gas.
Toxic gas, thank you. So radium is dangerous because of its long half-life. And its daughter product is radon, and it's dangerous because it's toxic gas. Do you really want to work with this stuff? No. So we stopped using it. So the very slow decay of radium makes it an excellent standard for which to determine the radioactivity of an artificially produced isotope. So, activity of an isotope is defined as the number of disintegrations per time unit, such as seconds, minutes, or hours. So a Curie was determined to be 1 disintegration per second, or 1 becquerel is equal to 1 disintegration per second. So 10 to the 9 times, no, 1 Curie equals 10 to the 9 disintegrations per second. I'll look that up and point that out for you. So activity of an isotope, because it's such an important concept, a special SI unit of activity, the becquerel has been defined. 1 becquerel equals 1 disintegration per second. Another unit which has been used for many years is the Curie. You'll still see that quoted, the Curies. So, the early experience with radium indicated that 1 gram of radium underwent 3.7 times 10 to the 10th disintegrations per second. And this disintegration rate of activity was later chosen as the unit of activity for all nucleides. Sample decaying at this rate was said to have an activity defined as 1 curie. Thus, 1 gram of radium has an activity of 1 curie. 1 milligram of radium has an activity of 1/1000th of a curie, or 1 millicurie. You might want to digest that one more time. Radium decays to form daughter substances that themselves were unstable. Decay of successive daughters eventually results in a stable substance that does not decay any further. The rate at which this decay occurs is characteristic of the internal nuclear structure of various daughters. And the most common one is radon. Half-life. So, time required for a radioactive isotope to lose half of its original activity is the half-life, T1.5. You know this, guys. You may just be asked it. The rate of decay of radium is very slow, and the half-life is approximately 1600 years. Half-lives of some of the radioactive isotope frequently used in radiation therapy is in the following table. So, you have radium-226, cesium-137, cobalt-60, strontium-90, iridium-192, gold-198, iodine-125, iodine-131, and phosphorus-32. Ignore the exposure rates. Half-life, so radium is 1600, cesium-137 is 30 years, cobalt is 5.26, average. Strontium-90 is 28. Remember, it's strontium-90 because there's another strontium-89. Iridium-192 is 74.3 days. Gold-198 is 2.7 days. Iodine-125 is 59.6 days. Iodine-131 is 8 days. And phosphorus-132 is 14.3 days. So, this is the MEV, 1.2, 0.66, 1.25-ish, thereabouts. Strontium is a beta emitter, so is phosphorus-32. These are the ones you should know. So isotope decay with half-lives ranging from microseconds to millions of years. And half-life is the present, and the present activity is known. It's possible to calculate the activity of a given isotope sample at any future or past time. The following slide shows the decay of some commonly used isotopes in radiation therapy. Straight line is drawn on a semi-logarithmic paper. Everybody know what I mean by semi-logarithmic? Anybody know what I mean by logarithmic?
Math.
Everybody's done, everybody's done algebra, right? Or math.
Grudgingly.
Would it be like graph paper?
Pardon?
Is it like graph paper? No? Okay.
What? Logs?
The paper, semi-logarithmic paper. That's kind of like graph paper.
It is graph paper.
That's what I was saying.
Anything you're showing as a straight line is usually on graph paper. We'll go over this, I'll let you look at it later. So, 226. It has been since replaced with artificially produced isotopes because it was just too dangerous to use. So, cesium-137, half-life of 30 years and has replaced radium as the isotope of choice for some gynecological malignancies. The gamma ray energy is 0.662 MeV, and cesium sources are stored in a shielded and secured room and are reused over many years. In radiation oncology, it's what most commonly used form is tubes, as in the gynecological applicators. Cobalt, 5.26 years. 2 gamma rays, 1.17 and 1.33. The average is 1.25. Cobalt-60 is an excellent use in teletherapy machines. It's still being used in most other parts of the world except for the US. First use was in Canada, Saskatchewan by Harold Johns and his colleagues in 1952. Cobalt has also been used in ophthalmic plaques for treatment of ocular melanomas. And again, these plaques are reused over years. Strontium, 90. Pure beta emitter. Half-life 28 years. Maximum beta energy is 0.454, The daughter product, yttrium 90. A beta particle with a maximum of 2.27 MeV. Dose rate on the surface of the plaque is 100 centigrade per second. Thus, each treatment is delivered in seconds. So you put a plaque over it, and you have a stopwatch basically, and you say, okay, go. Doc puts it over, and you say, okay, stop, and the doc takes it off. Iridium 192. Iridium 192 and Iridium 198 becoming more popular in brachytherapy days. Has anybody seen a brachytherapy other than gynae or SAVI? What do they use for SAVI? What isotope are they using for SAVI? Do you know?
It was iridium.
Iridium? Yeah. So it has 11 gamma energy ranging from 0.136 to 0.613. It's usually manufactured in the shape of seeds, approximately 3 millimeters long and 0.5 millimeters in diameter. Following removal, iridium seeds are usually returned to the supplier and are not reused because the half-life is 74.3 days, so it really doesn't give the time to reuse it. Gold, 198. Hasn't been used for a while, but it's a form of seeds or grains. Material is suitable for permanent implants because of its relatively short life, 64.7 days, which is 2 months, give or take. And most of the energy will have 0.412. Iodine 125, and I think this is the one that's usually used in prostate. Used in permanent implants, commonly in seed form, 4.5 millimeters long and 0.8 millimeters in diameter. Half-life of 59.6, the non-penetrating radiation absorbed by 0.05 titanium wall of the seed also emits 0.274 and 0.355 MeV photons. It can be used as a sphere with resin, also combined with a silver rod, also as a seed absorbed into tungsten wire. So 59.6 days for half-life. You put it into the prostate. How long would the gentleman have to do some precautions? So half-life is, give or take, a couple hours, 60 days. That's 2 months. So probably within 6 months, it would be almost gone. Or gone enough for him to stop, or to start being around kids again. P32 and iodine-131. P32 and iodine-131 are also used for therapeutic purposes. P32 decays by beta with emissions from a max energy of 1.71 and a half-life of 14.3 days. And I-131, the half-life of 8 days. Decays by beta and gamma emission, maximum energy is 0.723. P32 is used as an injection for bone mets from prostate. Don't ask me why it works. I don't know. I don't think anybody actually knows. All they know is it works. And I-31, 131 is used for thyroid. Okay, radioactive sources are specified by their physical length, active length, and activity or strength infiltration. So, you have, oh dear, here we go. Where did all my pens go? Okay.
I don't have my mom bag, I think.
No, that's okay, they're there, they're just way. Oh, it's pink. Oh, that's okay. So, let's get rid of the mantle. So you have a radioactive needle or tube. So say the physical length was 5 millimeters. The active length would probably be there to there. So the active length would be 4 millimeters. Because, so this is physical length. So the physical length is the length of the tube or the needle or whatever it happens to be. And then the active length would be less than that. So that's because they're wrapped up in platinum or yttrium or whatever it happens to be. The walls of each source consist of a platinum alloy and in some sources non-radioactive iridium which strengthens the walls. So you have two lengths, and this makes it so that when you're doing a calculation, you're measuring the active length rather than the physical length.
So 0.5 thick sheath of platinum surrounds the radium in sufficient enough to filter out all alpha and most beta particles emitted by the radium and its daughter products. The only gamma rays escape of radioactive material into the body and fluids. So cesium is most commonly available in the form of tubes that are 20 millimeters long and in diameter, with an eyelet near one end to allow suturing the tube to the tissues or some apparatus. The active length of the tube is usually about 14 millimeters, and the activity of each tube ranges from 5 to 25 milligrams of radium equivalent. So everybody, all of these calculations that are done that you won't ever have to do is in radium equivalent. So the seeds are one of the most popular forms of brachytherapy. Radium-192, most commonly used isotope in seed form. They're usually supplied in nylon ribbons with the desired spacing and activity. I-125 and gold 198, available in seed form but not usually in ribbons. These isotopes have a shorter half-life and are often left in place permanently, hence frosting. P32 is used in liquid form, deposited in the intraperitoneal cavity in an attempt to treat peritoneal seeding in ovarian and endometrial cancers. Strontium-90 is a saline solution that's been used to treat extensive metastasis. And I-131 is given orally in high doses to treat thyroid malignancy, while in low doses used for diagnostic purposes. So if you go to the doc and he says he wants a thyroid scan, they will give you an I-131 test, and if it is malignant, then they would give you a treatment with I-131. Radioactive isotopes being used in the form of ophthalmic applicators. Applicator using strontium-90 is often used in the treatment of pterygium, and I've got a photograph of this somewhere. A benign condition of the conjunctiva, the daughter product, yttrium-90 produces beta particles used in these treatments. So this is pterygium here and here. It's a benign condition, but it can be treated with the radioactive substances. And this is an eye plaque. So here's the gold sheet. These are the radioactive seeds. And it can be put basically anywhere in the eye. So here's the retina, cancerous tumor, and the plaque is attached to that area and the treatment given. And I'll show you some fancy pictures. Surface applicators. So head and neck. Recurrent persistent disease in the head and neck region. Because of their position, many of these lesions, the applicators can be placed directly over the lesion. This makes invasive procedures unnecessary. The applicators could be easily removed and repositioned, so many may in some cases be fitted during the daytime hours only and thus avoids hospitalization. So they go into outpatient facilities that are specially built, and they can be treated during the daytime hours. Or you can go into the cancer center and you can sit in a day room or whatever room they have, and you can go home at night. Implants in the oral cavity can be limited to sites where soft tissue surrounds a lesion. So this is an oral cavity, this is actually a mold, and this is perspex from that mold. This is obviously much bigger. This is a perspex from that mold, and these are tubes embedded into the perspex, and these are worn by the patient during the day and left in the department overnight. Nasal cavity, we're talking about the nasal cavity. So this may look evil, and it is. So let me just go back. Surface applicators can be used to boost the dose to small lesions in the nasal cavity, vestibule, and nasal pali. These applicators can be removed overnight so the patient doesn't need hospitalization. When the lesions are too thick for a surface applicator, then a second plane of radioactive ribbons can be implanted interstitially. This would require general anesthetic and hospitalization. Very detailed impression of the nose, particularly the nostrils, is necessary for a snug fit. So this was an impression, this was an impression done of the nasal cavity, and this was a perspex applicator used, and these are inside and they're attached to the HDR. Orbital cavity. So if they take the eye, they may need to treat the socket. When the eye is intact and the patient has a solitary lesion, a radioactive plaque can be used. If there was a recurrence following enucleation, then intracavitary implant may be feasible. So they basically put a radiotherapy plaque into there. So this is a child with retinoblastoma. You can see the eye, which is involved. So we would try and treat that with either external or brachytherapy. Brachytherapy is easier to do, depending on where the lesion is. But surgery is always an option. So basically we take the eye. External auditory canal, rare. The anatomy of the ear provides many structures that can increase the stability and the fit of an applicator. The appliance that you'll see in a little bit was made by an anchoring loop around the ear similar to glasses and placed in the ear. The needles were inserted under local, only a centimeter deep in the preauricular region. So this, it's not a very good picture, but can you see the shape of the ear here? So this is what they made. This is the loop that goes around the ear to keep it in place. And here was the tumor, so the lesion, the needles were put in this area. And here's the tumor here. Nasopharynx. What's the most common treatment for nasopharynx? What's the most common treatment for nasopharynx?
Surgery.
No,
Seems to be it for everything else.
it's radiation. Number one treatment for nasopharynx is always radiation, external radiation. So it can be used for recurrent, radiotherapy can be used for recurrent tumors in this area, but must be limited to small volumes. Intracavity placement using cesium-137 in the tube, secured or inside of an ovoid, which can be pulled into the cavity via, and I know it sounds evil, nasogastric tube. The diameter of the ovoid is important in maintaining an adequate distance between the source and the mucosa. The disadvantage of this technique is the necessity of hot loading, that is with radioactive sources in place. Another technique is to insert two endotracheal tubes into the nasopharynx through the nostrils. Balloons of the ET tubes are then filled with contrast using dummy sources. They check that everything is good, then the tubes are secured to the patient's nose. Tubes generally used in gynecological patients are loaded and introduced into the ET tubes. So these would go in to the nasopharynx, and these are balloons that they would be filled up and hold them there. Looks evil, I know. Interstitial breast implants. We're not talking about Savi or anything like that at the moment. Interstitial breast implants using iridium-192. Seeds are uniformly distributed throughout the target volume, resulting in a higher dose in the center. Nylon ribbons containing seeds are spaced 1 centimeter apart. Also continuous 192 iridium wires rather than discrete seeds may be used. These delivered more uniform. So with an activity of 0.33 milligrams radium equivalent per seed, those rate lines encompass the implanted volume is approximately 40 array per hour. There's no picture of this one. And then of course you have the Savi or the Mammocyte, which are also counted radiotherapy. Who's seen a Mammocyte or Savi? No? No? Okay, yeah. No, you haven't. Okay, let me show you something here that I found. I was looking for something else. So here is another picture of a pterygium.
They just did this on my glass.
Whoa, that was weird.
This is a Burkitt's lymphoma. You remember us talking about Burkitt's lymphoma?
Yes.
Well, this is a Burkitt's lymphoma. You can see here it's rather nasty.
Looks painful.
It's these teeth, so it's basically in here. Kaposi's. This is one picture, particular picture of the Kaposi's.
Oh yeah.
That's one way, and these are the ones that I'm going to show you are both age related. This is 1 and 2. See what I mean by a bruise? That's your normal, that's how kyphosis normally looks. This could have either been classical or age-related, but in this particular patient, it was age-related. Anybody done a keloid yet? Yeah. What are keloids?
Built up scar tissue.
Built up scar tissue, okay? What do they look like?
Like a lump.
Shiny
Big scar
nodules.
tissue. Pardon?
Big shiny nodules.
Big shiny nodules. I
Shiny.
thought you said it was scar tissue,
They're pretty
Yeah.
thick.
but not necessarily shiny. This
Skin is
is,
pretty tight over them.
okay, yeah,
I have a keloid on my hip from I got bit by a spider. And then I had it scalpeled and drained. You see it?
this is a keloid.
No. Actually, it's going down now. I'll stop holding it.
Not very, this is actually fairly common.
Yeah.
This is probably the most common site for a keloid, is you get your ears pierced. And in some, it's unusual because this is a white girl, it's more common in darker skinned.
I had one when I did my cartilage, but it's because I did it in like a hotel room in Europe somewhere when I was 15. And I had to take it out, but it went down by itself. I don't know how it.
You were lucky.
Yeah, it just went away by itself. But that's because I didn't continue to put it in there.
It's another keloid.
Yeah, that's more what it looked like.
My friend has one that's like round
Yeah,
on her ear.
mine is just
That's
very
what it usually
small.
looks like.
Yeah, that's what my hip looks like too.
But normally you would get them, the most normal place is on the ear. Bless you. The problem is that once you keloid once, anytime you have any kind of surgery or any kind of cut that needs to be stitched, you could keloid again.
Oh no.
Yes. So I say could, not necessarily. In some patients, yes, you can say, yeah, you will keloid again, but different type of skin. So this is just out of sync. Where, if we were going to give a kidney transplant, where would they put it? If you need a kidney transplant, you know where the kidneys are, right? They're up here somewhere. If you're getting a kidney transplant, where in the body do they put it? Or where, I'll make it a little bit easier. Where in the abdomen do they put it?
Can't remember, but I remember us talking about it.
Uh-huh. Let me show you. This is just a diagram. So these are the two kidneys that aren't working anymore. This is the transplanted kidney. So you see the transplanted kidney and the ureter as well. So they put it basically lower abdomen, upper groin. That's where they put it. Just a useless piece of information. Okay.
No wonder why my brain
So-
pushed it out.
Was somebody talking about doing a patient with a Merkel cell? Somebody was. Anyway, this is what a Merkel cell looks like. So these are two different Merkel cells. This is one. This
Did
is
you look
another.
to see what that guy's was, Morgan?
So they're
Did you see what
skin
that-
cancers, but they're just different. So what is your patient with the neck?
It looks kind of like the one on the right.
What?
All
Yeah.
I know is the chart says squamous cell carcinoma.
Squamous cell carcinoma? Okay. Then it's a skin one.
Yeah.
Yeah, okay, it just grew.
Yeah. And apparently it grew very fast because he had, like a surgery 5 months ago
Uh-huh.
and had a skin graft. They took skin from his thigh and put it
Over
up
there.
here, and then within 5 months it got that big. So I don't know. That grew fast.
Okay.
So, can I ask you a question?
Sure.
Sorry, are you guys done talking about that? Okay. So, it's about the Merkel cell. So, my friend has this, and
Oh my
she
goodness.
thinks.
Hold on.
What?
I have one on my arm too.
Oh, please.
It's the same one every.
So she's had it for like a year, and she had it when she was pregnant, and then after she gave birth, it like kind of went, like it started getting smaller, but then recently it's been getting bigger and growing, and it's like all red around it. She thought it was
It could be, that's what I was looking at actually. So did it come up while she was pregnant, or did you have it
I
before?
think she had it before.
Okay. Did it grow when she was pregnant?
It grew when she was pregnant, and then after she gave birth, it shrunk, and then it's been growing again. And now it has like red around it.
Red around there, yeah.
I wanna
I
see.
would get her to go see a dermatologist myself, but
Yeah.
it could be,
I've been trying.
it
she
could
has
be
no
anything.
They try to get me to go to the doctor too. But I'm like,
It's all her
They'll just
thigh.
lop it off, whether they know what it is or not. They're not playing around. They just
that's
take
what
it
I
off.
figured. I could go to the doctor to the.
Yeah, it looks like it has like a little pigment on it.
What part of their body is this? Oh, is their thigh? Those are probably hair follicles, those two holes.
She's had it for like a year
I'm
and a half.
thinking it was a bite of some sort.
It looks like it, but she's had it for like a year and a half.
Yeah, well, certainly not bite.
Because her son's 7 months old.
Well, I have seen spider bites scar up like that. It's like a stinging,
Mhm.
if some spiders have like those little.
Yeah, it does look like a spider
Could
bite,
be.
but after a year and a half.
Well, yeah, my brother got bit by something, by a spider, and he had a scar for like 3 years, and it was very red and angry for a long time.
Mm.
I would see if you could persuade her to go and see.
Yeah, she has an appointment, but it's
The
like
fact
2
that
weeks.
it responds to hormones is, doesn't go set up with bug bite.
Yeah.
So,
And why it, because it responds to hormones, it doesn't meet any of the criteria for cancer stuff. But
Okay.
you never know, stranger things happen. So anyway, to get back to
So it's
ears,
strange things
mycosis,
definitely
fungoides, one that I see.
I told you every time I'm out in the sun, I get this line.
This was a generalized one,
It goes down to my chest.
and you can see the big
Really?
Well, it
lumps
looks
and
like
stuff
it's
here.
There's like this side of
Here,
the
here,
at all.
here.
But on the right side of the line,
Those
it's
were
all
treated
tan.
with
It's
just
weird.
normal electrons.
Good.
And this other one was on his scalp.
Oh my
You can see a big one down here. That was nasty. But at least it hasn't started to fungate yet. Nasty when they start to fungate. Or they burst and it's all over the place. So while we're in this one, we'll show you some pictures of some of the machines you probably have never seen. This is a very old cobalt machine. This part, the source is in here. This part does two things. It is actually a counterweight because this thing is heavy, and it's also what they call a beam stopper. So it stops the beam and you don't have to have as much shielding. Veritron. You can tell how old this thing is. This is one of these things. This thing is all Beratron. This is the machine. It's huge. And the angles, it basically had to move the patient to match the machine. It didn't move too much. It angled this way, but it didn't angle any other way. And this is a CyberKnife. So you can see this is the small linear accelerator. And this angles various shapes and sizes and movements and stuff. And then this is the bed, so it can move various ways. It can angle this way and this way and this way. It's a very interesting machine. But very slow to treat. And again, Beratron, you can see the size of this one. And the ortho voltage. This was a Siemens, 250 kV, approximately 250 to 300. And this was the cone. This came down to actually touch the patient and treat them that way. And this thing would move this way, and it could move this way, and it could move up and down. Interesting little beast. And the Van de Graaff. Again, you can see the size of it. Nobody uses these anymore. Just give you a history lesson. This is a Theratron. This is a newer version of the first one that we saw. It's a Cobalt 60 machine. The source is here, and it can rotate around 360 degrees. You can do art therapy on this one. But again, nobody uses them in the US. There is more up-to-date ones, but that's basically what it is. So, questions? Oh, before we go, I will read my little notes because of people not coming in until later. Next week will be exam review on the 29th. The final exam is the 6th of December. The last day of clinicals. Oops, sorry. Whew. The last day of clinicals is the 10th. I need you to either bring all of your paperwork to me on the 6th or email it to me by the 10th at the latest. Because I can't give you a clinical mark unless I have the end of semester eval from your instructor, from your preceptors. And the start of the spring semester is the 10th of January, so you have a month off. Goodie for you. Yes, ma'am?
I have one question about that. So my husband's last chemo was pushed off until the 14th
Of
January.
January, okay.
So, well, I just
Take
have
that
to.
L for the week.
Well, yeah. Should I just start a week late, or go in on Tuesday and be like, I gotta have off Friday?
No, you start on Monday through Thursday.
Oh.
You'll be off on Friday.
You'll be off on Friday.
The last semester will be
Oh.
on Friday.
When are we?
It's gonna
When
be
are we gonna be here then?
Friday.
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 Oh. Oh. Okay.
That's so weird.
Yeah, it's gonna be.
Not really, because I have another classes Monday and Tuesday, so.
What class? What class is more important than us?
What do you mean more classes more important? I have a new group of certificate certificate students coming in.
Oh,
starting
certificate students.
Wow.
Okay.
No, I always do
fancy,
the
huh?
the Friday morning for one.
So are we gonna be working on the virtual?
Sometimes.
Yeah, can we just finish on the
That's another reason why
We're doing
we do it on the Friday.
There's a couple.
Because it's easier to get into the vert machine on a Friday than it is on a Monday or a Tuesday.
There's just a couple comps I'm worried of, because I've not seen any of them. I just don't
That's
know.
okay, you've got all of till May to get them. And we could always
What are you
do
stressing?
some in class.
Okay.
So, don't worry about it.
Yeah,
You get
worried.
there.
So we have a certain amount of dosimetry comps and a certain amount of CT
No,
comps.
you only have, you don't have comps for dosimetry.
Okay.
You have,
One dosimetry.
you have dosimetry.
Okay. I did that. But I saw something about dosimetry comps. And then the CT, we have to have a certain amount of comps in CT. Okay.
7.
Yeah,
Sounds great.
so whenever
Sounds
you
super
go
great.
next time, make sure that you get your CT